Welcome. I'm Lowry Barnes, Chair of the Department of Orthopaedics at UAMS. This is our OrthoChat session, and we welcome you to it. We are very lucky today. We have Dr. Justin Rabinowitz with us. Dr. Rabinowitz is a shoulder and elbow specialist who joined us a couple of years ago, and we have been so proud to have him as one of our partners. He's done great things for many Arkansans, and he's a great partner to us. So Justin, welcome.
Thank you. I'm happy to be here.
So tell us about yourself. So where'd you grow up? Where'd you go to college, med school, residency, fellowship? Now our viewers don't understand what we go through to get to be a subspecialist. So take us through your pathway.
Sure, absolutely. Yeah, it's a long track. I actually grew up in the suburbs of Atlanta, Georgia. And then after Atlanta, I actually went out to Arizona for college. And after college, I made my way to the Midwest, to Chicago, and I went to medical school at Rush University. Spent 4 years in Chicago, and then after Rush, I went to Charleston, South Carolina, down to the Low Country to do orthopedic residency. Spent 5 years in Charleston. While I was there, I met my wife, Hannah, and so she kind of joined this path with me. And then while I was in residency, I got interested in shoulder and elbow surgery. I developed some good relationships there with some mentors who kind of helped me along the path and led me to interest in shoulder and elbow specialty. And so I ended up at Washington University in St. Louis, where I had an amazing year of training. And while I was in St. Louis, I was fortunate to hear about this position at UAMS, and I was interested in academic orthopedics, and I wanted a job where I could really focus on shoulder and elbow surgery like I'd been trained for the previous year, including both non-operative care, arthroscopy procedures, and reconstructive type surgery. And so I was fortunate to find UAMS, and here we are now. So it was a long path to get here, but I kind of made full circle back to the southeast, and we're happy to be in Arkansas, and I'm very happy to be at UAMS, and it's been an amazing 2 years so far.
Well, we're really glad you're here. You mentioned your wonderful wife, Hannah. Tell us about the rest of your family. You started out with a bang when you got to Little Rock.
Yeah, we did. So I met Hannah, again, like I said, in Charleston. She grew up in Charleston, South Carolina. And while we were there, we had our first son, Hudson, who's now almost 4. And he went with us to St. Louis, and we all lived in a small little apartment together for a year. It was a great year as a family. And while we were there, we had another surprise, and Hannah got pregnant with our second son, Connor. And so when we moved to Arkansas, Hannah was pretty far along in her pregnancy, and after a few months of being here, we ended up with another son. And it was important for our family to grow like that, but it was also important because it taught me something else about UAMS, because it wasn't a traditional childbirth. It was a little bit of a traumatic entrance into the world, and so we were actually had the opportunity to be patients of our own at UAMS, and Hannah spent a few days here, and Connor spent some time in the NICU, and so it was a chance for us to see truly how special UAMS is, not just from orthopedic surgery, but also just the other specialties that are here, and the physicians and the staff that are here are unbelievable.
Yeah. And it gave our department a chance to show you that we really are a family. And so I think you saw tons of outreach from the department during your welcoming here. So,
right.
But it's been a lot of fun having you here. You've really developed your practice very quickly. What do you like most about shoulder and elbow surgery? What made you decide shoulder and elbow? They're like, lots of different fellowships you can do.
Right.
And you might tell the viewers what it means to do a fellowship and to specialize in one area.
Sure. So for me, when I went into my residency, I kind of went in with an open mind and tried to learn as much as I could from all the different fields that we get exposed to, and we're fortunate to have that opportunity in our residency. But throughout the first few years, I sort of started gravitating towards patients with upper extremity conditions, and I liked the ability to rehab patients with conservative treatment, whether that be physical therapy, other special types of modalities for pain, and other conservative measures, but also the chance to do sports types of procedures like arthroscopy procedures, and then reconstructive surgery like arthroplasty and joint replacement. And what I really enjoyed seeing was how well patients did after some of these procedures, and how much I could truly have an impact on their lives. And then I had mentioned some relationships with mentors of mine who really helped guide me in that field and kind of got me on this path. And I've continued those relationships to this day. And I think that's something that's important in medicine in general. But from my initial interest in this field to now doing it as a as an attending and a physician here, I'm so happy and thankful that I chose this path because it is truly rewarding.
Good. And am I correct that shoulder and elbow is all you do? You don't do ankle, knees, hips, neck,
Yes.
back, right?
So at UAMS, we're very specialized, obviously, as you know, and I think that's I think personally that's an excellent thing for medicine. I think having specialization is important. I think that we deal with complex issues that need somebody who is really focusing on that area. And so my practice is basically 100% shoulder and elbow pathology, and the majority of the patients I see are patients with those issues.
Sure. When people think about the shoulder, most people think about rotator cuff. As you know,
Sure.
It's often not described as rotator cuff. We hear things like the rotator cuff. I had my cup fixed and things
Right.
like that. So a lot of people have heard rotator cuff, but they don't know what it is. So what is the rotator cuff?
Sure. That's a great question, and it's a common question that we face in practice on a daily basis. And what I like to explain to patients is the rotator cuff is actually 4 muscles that then become tendons that then attach to the humeral head. And the
humeral head is the
humeral head is the upper part of the humerus that makes part of the shoulder joint. And so similar to the femoral head for the hip. And so the rotator cuff are 4 muscles and tendons that surround and attach to the humeral head and create this cuff of tissue. And that's where we kind of get this terminology, the rotator cuff. And the rotator cuff is important for multiple reasons, but it's a dynamic stabilizer of the shoulder, which means that when we move our arm in space, the rotator cuff's job is to keep the humeral head centered in the socket. And so when the rotator cuff fails or you have rotator cuff tears, it leads to things like pain, it leads to weakness, and it leads to significant dysfunction when it becomes advanced kind of failure and tears in the rotator cuff muscles, particularly when it involves more than one. And so the rotator cuff's job, it's an important stabilizer for the shoulder, but it also provides strength and function for our arm.
Correct. So how do they tear? Is it an acute episode, or does it happen over time, or both?
Right. That's an excellent question. I like to break it down into 2 categories. There's degenerative tears, which are tears that happen over time. Wear and tear, the tissue quality worsens over time.
More in my age.
Yeah. I don't want to call you old, but it does happen in patients kind of middle to older patients. It's common to have degenerative type rotator cuff tears, and actually they're so common that a majority of patients that have them never have symptoms from them. But in general, I like to break it to those 2 categories. You have the degenerative tears that are wear and tear. They happen over time because tissue quality worsens, and sometimes they're not even symptomatic. And then you have traumatic tears, and traumatic tears are tears that happen as a result of an injury. So car accident, a fall, skiing accidents, playing a sport, and the arm gets put into a position where the rotator cuff has a traumatic tear, similar to when somebody breaks or fractures a bone. And so I like to, in general, I speak with patients to talk to them. It's important to think about them in those 2 basic categories because it really guides the treatment of these tears.
Sure. Now, I remember from residency days that when patients would dislocate their shoulders, they would sometimes find out after the fact, after their shoulder dislocation was treated, that they had a rotator cuff tear that went undiagnosed. How often does that happen, and how do you prevent that from happening?
That is an excellent question, and that's another type of tear that fits into the category of traumatic rotator cuff tears. And so in patients really who are over the age of about 50, if you have a shoulder dislocation, almost 100% of the time there's an associated rotator cuff tear with the shoulder dislocation. And oftentimes those types of rotator cuff injuries can go missed because somebody had a dislocation, so we think it's normal for them to hurt and to have weakness, and then we put them in a sling and we wait. And those patients in general, if I see somebody who's like middle-aged patient who had a shoulder dislocation, I follow them closely because I want to be able to examine them as their pain improves to assess for weakness and functional deficits.
Right. So how often do you get an early MRI on those patients? So I assume MRI the way to diagnose cuff tears mainly?
Absolutely, yes. That's right. So most patients in general get an x-ray when we see them. And x-rays can be useful for patients with advanced rotator cuff disease because of that destabilizing of the shoulder like we talked about. But in general, to diagnose a rotator cuff tear, you need to have either an MRI, a CT scan with contrast in the shoulder joint, or an ultrasound. But an MRI is by far the most accurate and sensitive way to detect a rotator cuff tear. And so if I see a middle-aged patient who had a shoulder dislocation, I'll usually treat them for a few weeks in a sling and then do a little bit of rehab. But usually between 2 to 4 weeks, I'm going to likely be getting an MRI of that patient's shoulder, because I want to be able to address that injury sooner rather than later, because it's a traumatic injury.
Sure. You mentioned on plain x-rays you can see because evidence of a cuff tear because the ball's not stabilized. What happens? You mean the ball's coming out of the joint, or what?
Yeah, in a sense, that's correct. So when somebody has advanced rotator cuff disease, so they've had and usually it has to be at least 2 of the 4 rotator cuff tendons are torn. And when that happens, actually, that humeral head that typically sits centered in that socket can actually start to migrate up or forward in the socket, because, like we talked about previously, the rotator cuff is a dynamic stabilizer of the shoulder. So when those muscles are torn, the humeral head is no longer being centered in the socket, and so that leads to dysfunction. And if we get x-rays for patients like that, we can actually see that the humeral head is sitting up in the socket, which tells me as the practitioner that that person has rotator cuff disease. I can diagnose that without getting an MRI.
That's my question. Okay. And so what's a likely scenario? A patient starts having shoulder pain and they're 60. And how long do they put up with it before they come see someone like you? How do they manage their shoulder pain initially? They see you, and then what happens?
That's a good question. So shoulder pain is extremely common. I think probably one of the more common musculoskeletal complaints in general is shoulder pain. And I think that patients who have shoulder pain, that's kind of like that wear and tear type pain. It hurts, but not a lot of weakness. I think it's very reasonable for that patient to treat themselves conservatively with some anti-inflammatory medications, talk to their primary care physician, and do some physical therapy to work on strengthening the shoulder, improving their posture, getting the range of motion back to normal. It's those patients that have persistent pain that doesn't respond, over a period of a month to 2 months, or patients who have weakness in their shoulder, patients who are having severe pain at night and it's affecting their ability to sleep. Those patients that are affecting their quality of life by their pain, those are the patients I want to see in clinic, because I think there are ways that we can help manage their symptoms, whether that be conservative treatment with focused physical therapy, or whether that be talking about other potential surgical options for them.
You brought up night pain. Why is it that for some reason shoulder problems seem to be worse at night? So many patients come in and complain, I'm fine during the day, but my shoulder kills me at night and I can't sleep.
Right.
And their spouse can't stand it anymore either.
Right, yeah, they're moving around in bed, they're keeping their spouse awake. Another very common shoulder complaint, and part of the reason is that in the shoulder there is a bursa. Just like we have bursal sacs in other parts of our body around the hip, the knee, the elbow. And again, a bursa is basically a sac of fluid that allows the tendons to glide smoothly. That sac of fluid can become inflamed and can become painful. And in the shoulder, there's a bursa, and so you can develop something called bursitis that causes this inflammatory type pain that can cause a sort of a throbbing type pain in the shoulder, and then particularly when you're not using it or moving it, like at night when you're sleeping, you sit there and you think about that throbbing. It keeps you awake, and so when I hear that complaint, usually I think of bursitis.
Okay. And
so it's that, and again, that's something that can respond well to conservative treatment, whether that's a prescription anti-inflammatory medication, physical therapy. We use steroid injections for that. I don't like to do repeated steroid injections, but for that patient I see that comes in and says, I've been having horrible night pain for the past couple of months, I can't sleep, and if on their exam they've got good strength, but it's mostly a pain issue, I think that's a great patient that would benefit from a steroid injection to bring down the inflammation in the bursa and decrease that bursitis in their shoulder.
Great. So patients can have bursitis and rotator cuff tear at the same time?
Absolutely. Okay. And sometimes actually the rotator cuff tear can lead to irritation of that bursa, and that can cause the bursitis. And so oftentimes they do go hand in hand. So that's why the physical exam and the history is so important to try to detect weakness in that shoulder, because if there's weakness, it's something that we might want to be more aggressive about treating.
Okay, now, what about impingement? What's that mean in the shoulder?
So to me, impingement, it's kind of on the continuum of subacromial bursitis or bursitis in the shoulder. And oftentimes, and something that I don't think is talked about that much with shoulder rehab, is the importance of posture. And as we age, it's very normal for our shoulders to roll forward, and for our posture of our shoulder blade or our scalp.
Why'd you look at me when you said that?
I needed an example, and it can actually happen to anybody, even starting in your 30s. It can happen. We see young athletes with impingement problems because of the way they've trained for so long, and their mechanics change. But in general, when the ideal posture is shoulders back, and that helps our the glenohumeral joint, which is that ball in the socket, move and function correctly. But when the shoulder blades start to roll forward, that can actually cause the mechanics of the shoulder to kind of be off, and it leads to more of these impingement problems. And what impingement actually is, it's essentially the rotator cuff and that bursal sac being compressed between the humeral head and the outer part of the shoulder blade, and it causes this pain up in the front. So for those patients, if you can improve your posture and get your shoulder blade back, it can actually help impingement. And so that's somebody who absolutely needs to do physical therapy to focus on improving posture, strengthening the muscles in our back, the muscles that attach to the shoulder blade in the back that help bring us back. And those patients, if they stick to it, will get better, and we'll see improvements.
Are there things patients can wear to help with their posture?
There are some braces out there. I think most patients find that they're uncomfortable, a little cumbersome, but there are things that we can use and help facilitate patients, really to help train them what it means to keep your shoulders back and improve your posture.
And so that's prior to a tear. So
correct.
Once you get a tear, and I understand there are 4 tendons,
That's
so
right.
I assume you can have one tendon involved or all 4 tendons involved.
Absolutely.
So kind of go through that algorithm. How do you manage those patients? And I assume some can be full tears, some can be partial tears.
Right.
And is the management different?
The management definitely is different, and it's on the spectrum. So you can have a partial thickness tear, which I think there's a confusion about what that means sometimes. I know some patients will get an MRI and they'll come to clinic and say, well, it says I have all of these tears in my shoulder. But what it really says is there's a partial tear of the supraspinatus tendon. There's a partial tear of the infraspinatus tendon. And what that means is actually that where the tendon attaches to the bone, there's still fibers of the tendon that are attached to the bone, but some of those fibers have torn.
Is that like a bad tendonitis then, or is it?
It is, in a way, it's like a bad tendonitis. It's like a bad muscle strain.
Okay.
And it does not mean that you have a full rotator cuff tear. This is extremely common. Again, and just to use you as an example, not because you're old, but if I was to get an MRI of your shoulder, you were going to have a partial thickness rotator cuff tear.
Right.
And that's normal. That's normal part of how the body changes over time. It doesn't mean that you have pain, it doesn't mean you have weakness, or it doesn't mean that you need surgery, but it's something that we're going to see. But some patients can have a partial thickness tear that is symptomatic, and that hurts. And so for those patients, I typically start with conservative treatment, whether that's pain relieving medication or an anti-inflammatory medication, to help with the pain. Again, therapy I think is the mainstay there. And then that progresses to the full thickness tears, which again I break into the 2 categories of degenerative and traumatic tears. We talked about impingement problems. The impingement is something that can lead to degenerative rotator cuff tears because it's that abnormal mechanics in the shoulder that leads to this pressure on the muscle that leads to a tearing over time. Those tears, I try to start with conservative treatment. The patients that don't respond to conservative treatment will benefit from surgical intervention.
Okay.
Typically, for me, surgical intervention for a degenerative full thickness rotator cuff tear that has not responded to conservative treatment, meaning no surgery, is somebody that I think can benefit from an arthroscopic procedure.
Okay. And so I'm glad you brought up arthroscopic procedures for cuff tears because, relatively new in the last 15, 20 years become much more popular to do these arthroscopically.
Absolutely.
So compare and contrast the previous way rotator cuff tears were fixed versus the arthroscopic approach. And you might describe what arthroscopy is because some of our viewers may not know.
Absolutely. So that's right. There's been historically, surgery in general was performed with open means, meaning a big incision, a bigger exposure, going between muscles or splitting muscles. to address pathology throughout the body. And in the shoulder, that meant in order to get to the rotator cuff, you had to move the deltoid muscle out of the way or go between the deltoid muscle. And that's historically how rotator cuff tears were fixed. But over the past 20 years or so, arthroscopy has become very popular. Arthroscopy is essentially using a camera to go into the joint to fix the tear from inside the joint through small incisions around the shoulder, using instrumentation to assist with that. But in general, it means that we're doing things from a minimally invasive approach, looking from inside the joint. So we no longer have to make a big incision on the outside of the skin to get down to the source of the problem. And this is something that's seen in other areas too, like general surgery in the abdomen for removing gallbladders and things like that. So it's similar, and that's kind of where it evolved from. So in general, that's what arthroscopy is.
Sure. So very much like what we've done in the knee for years,
Absolutely.
now it has been moved to the shoulder.
That's right.
So for our viewers, if you've seen, you heard patients having, or you may have had, a cartilage tear in the knee, it is most likely was treated with arthroscopy. And now Dr. Rabinowitz has that same technique available for the shoulder, so it's less invasive.
Right.
Now, so those are, you talked about those degenerative tears. What about the acute tear? The 30-year-old who is playing sports on Saturday and had excruciating pain in their shoulder, felt the incident happen, and saw their doc, went to the emergency room, and they see you the following week. How's that patient managed?
That's an important question, because it's something that I think gets confused oftentimes. And that person who has that acute traumatic tear, I want to know about as soon as possible. That's somebody who I don't recommend tries conservative treatment. If they had an injury, they had a normal shoulder before, they had their injury, and now they have pain and weakness, particularly in their shoulder, we need to get advanced imaging for that patient, which means MRI, CT scan, ultrasound, to find out if they've torn the rotator cuff. If they have a rotator cuff that was an acute traumatic injury, that patient will benefit from having that injury fixed. I explain that to patients that it's similar to breaking a bone that's unstable. It needs to be fixed. It's not something that we should treat conservatively. It's very different than the degenerative rotator cuff tear.
Sure. So, okay, great differentiation between the acute tear and the chronic. What about the management afterwards? So you take the patient in the operating room, you perform an arthroscopic repair, and can you repair one tendon, two tendons, three tendons, four tendons? How many of those rotator cuff tendons can you repair arthroscopically?
So in theory, we could repair all four of those rotator cuff tendons arthroscopically. The most commonly torn tendons are the supraspinatus tendon, which is the rotator cuff on the top of the shoulder,
okay,
and the infraspinatus tendon, which is the rotator cuff in the back of the shoulder. And those are the two most commonly injured rotator cuff muscles and tendons, and so that's usually what we're addressing. Sometimes the rotator cuff muscle in the front, the subscapularis muscle, can be injured. That's more common to be injured from a traumatic mechanism. But yes, we can address all of those arthroscopically.
Great. And so what happens after surgery? Suppose you fix my rotator cuff tear later today. What happens over the next few weeks or months?
So this part is where I really want patients to understand that a lot of this is on you, and your recovery is important for you to be actively involved, because my job is to go in and to repair that tendon back to the bone and create a good surface for it to heal and make sure that it's secure and stable. Your body then has to heal that. My repair actually is not strong enough to allow you to go and necessarily lift your arm up and move those muscles. Your body needs to heal that first before we get to that point. So the first 6 weeks after surgery, it's a little bit difficult on patients, and I'd like to make sure they know going into it that this is something that you're really making an investment in, because you want this to heal. We don't want to do this again. And so that first 6 weeks, it's all about it's rest. It's you're spending most of the time in a sling. We're managing your pain. I allow you to move your elbow, your wrist, and your hand, but I really try to limit the amount of shoulder motion for the first 6 weeks so that the tendon begins to heal to the bone. At the 6 week mark, get rid of the sling, hopefully forever, and then it's time to start physical therapy. And we have specific protocols that we've developed to help guide therapists and patients so that they progress at the pace that we hope.
Great. So it's an active community. Golf, pickleball, tennis. When can they go back to these activities?
That's a good question. And the goal for everything that we're doing is to get patients back to being functional, get patients back to doing things that they enjoy, back to improving their quality of lives, really. And so my goal for all my patients is to get back to their pre-injury activities. And so for a rotator cuff injury that was fixed, really you're looking at between 2 to 3 months before you can start easing yourself back into those activities. That doesn't mean you get back and you're taking a full golf swing. That doesn't mean you're getting back and doing a full competitive pickleball match, but it does mean that you're working yourself back to that. And I hope that by 3 months you're back to those activities.
That's great. So, we have something exciting happening at UAMS. Tosh, the Orthopedic and Spine Hospital at UAMS. We opened in June 1. How's that going to affect your practice and help your patients?
So I'm very excited about Tosh. I think that it's going to have a huge impact, not just on my practice, but on everybody's practice in our department, but really on UAMS as a whole. I think that it's an area for patients around Arkansas to come to get treatment, to get specialized treatment, to have where we're all under one roof. We're all kind of working towards the same goal of getting patients back to their function, improving their quality of lives, and it gives us a good area to accomplish those goals, but to work together to accomplish those goals. And so for my patients, from a practical standpoint, it's easy to see from the highway. They're going to know exactly where this building is. The difficulties of getting to a big hospital, finding out where the operating room is, finding out where clinics is, I think that's going to become so much easier for patients. So the access is going to be a huge improvement, especially because we're treating patients from all over Arkansas. And it's just going to be, I think, a staple of what our mission is and our goals are.
Right, and we certainly hope so. Our so-called tagline, which we really don't have a tagline, but our saying is that Tosh is going to be where motion lives and service leads, because we really do want to make it a patient-facing, patient-centric approach. And, having young surgeons on staff like you, no doubt that's going to happen. I can't tell you, Justin, how glad we are that you're part of our team, and thanks so much for taking time with us this morning. And patients are going to benefit from what you told them today. So thank you.
Absolutely. Happy to be here. Thank you.